Thank you for inviting me, and I'd like to thank the CSEP for giving me the opportunity to talk to you today. And I'd like to thank you to be here. I want to say that although I'm a researcher in this field of personalized nutrition, the social, ethical, and legal aspect of it is not my personal field of research. However, I give an elective course in the School of Nutrition at the University of Ottawa, and this is the part that interests or engages the students the most. And I thought that it would bring those issues to you because it's important to reflect on this before we kind of embrace this field. So I'm not sure how it. Okay, so this is the outline of the presentation. I'll cover a lot of topics, mainly ethical, social, and legal, and I'll use a case study to give more concrete examples or make it more realistic. So think about this. We already have a lot of factors that we can use to personalize our dietary advice. So whether you're a toddler or a senior, or if you're a man or a woman, your nutritional needs will differ, and we need to take that into account already. If you're physically active or not, etc. If you're pregnant. So genetics there's an echo. Maybe I should. Genetics is another factor that we can use to even personalize even more our dietary advice. But we have to keep in mind that it's one aspect, and we already have a lot of other aspects that we're already using. And so, yes, we can use all of it in terms of disease prevention, but we can also use it for, to have optimal health or, to optimize your performance, etc. So, this is my case study. So let's say that this is Mr. Aurora. He's a taxi driver. I just noticed recently that he's driving on the right-hand side, so visibly he's not in Winnipeg. But let's say that he's a Canadian or he immigrated here. He has hypertension. He had a first event of myocardial infarction, and he wants to prevent another one. He doesn't want to have another heart attack, so he's wondering, well, should I use this nutrigenetic test? And by the way, he's married, he has child and grandchildren. So again, what should we think of or about before we use these tests? So before we move on to the ethical considerations, I'd like you to think about different questions. So will he have an equitable access to this service? Will he have the opportunity to give a free and informed consent? And will he receive information from trained healthcare professionals, or maybe just direct to consumer, just a report, so no advice that comes with it, or no exchange with the professional? So these are some principles of ethical conducts, or others, but justice, equity, fair access, autonomy, etc. So really what we might want to think about is we want to avoid increasing the inequalities between the rich and the poor, because the rich already, they're rich, they're doing better, they have better access to different services, they exercise more usually. And the poor are, at the opposite. So do we want, again, with nutrigenetics, to increase this gap, or we want to make this nutrigenetics as part of our universal healthcare system, but we have to keep in mind that we have scarce resources. And so we'll have to think about the cost benefit of it. Do we want to sequence all the population and start doing very personalized advice? Can we afford it? If not, again, will it be only the rich who can afford it, who are better off anyways? So let's say that we move this on into the healthcare system. Well, we really need to have trained professionals who will give those advice, because it can be very complex. Now we're using high throughput technologies. We have millions of genetic variants analyzed, or gene expression, millions of output of results, and we have to make sense of it into very clear and concise advice to the public or to our clients. And currently, physicians have very little knowledge of genetics and nutrition. Dietitians have a lot of knowledge in nutrition, but very little in genetics. So we have to start including these concepts or these into the university curriculum. And there was a study that was done, it was a survey among dietitians, and most of them were saying that they didn't have enough knowledge to actually embrace this field and give advice to their patients. Now, the new generation is getting, more educated. My students have, well, my course is an elective course, but at least in the first year course, I give one lecture on nutritional genomics. So it's a start, but we really have to think about, how we want to make sure that our healthcare professionals are well trained to give these the advice. Now, let's say that they're well trained, then we need to make sure that the clients or the patients will be able to provide a free and informed consent. So free means that the person will give that consent free of any pressure. So the healthcare professional should not receive money if he sells more nutrigenetic tests, right? Or if the company sells it direct to the consumer, he shouldn't sell a supplement. Let's say you need more folic acid, he shouldn't sell you a pill of folic acid, right? There's a conflict of interest there. Or Mr. Aurora's wife shouldn't pressure him to make this test. It has to be, his own choice. And informed consent, it goes back to the training of the person who will give the information. Will he receive clear, concise, or enough information to make an informed decision in plain language? Because it can become very complicated, right? When we talk about SNPs and whatever, genotyping, they might not really understand what it means. And they have to be informed of the risks and benefits associated with it, but I'll cover it a little bit later. Now, you have to know that there are millions of genetic tests available worldwide, literally. And all of these different tests don't look at necessarily the same genetic variants, and they maybe not use the same studies to, let's say one SNP is associated with cholesterol intake from dairy products, or with folic acid, or with omega-3s, or coffee intake. They might not only look at different variants, but base their advice on different studies who might actually give conflicting results, and they might use different methods, sequencing, genotyping, whatever. So it could technically happen that the same person would send his saliva with DNA sample to different companies and receive different advice. It is possible, so what do we do? Maybe we need a little bit more science, or replication at least. Okay, confidentiality of result. We know that genetic information is very sensitive, and it can have important consequences, right? Let's say that you know that you carry one variant that Peter talked about, and you're like, oh yeah, I should eat more phytosterol, I'm a good responder, that's great. But let's say that 10 years down the road, this variant is associated with Alzheimer's disease, or high, probably not cholesterol in Alzheimer, but it's just hypothetical. Let's say that we don't know now, but eventually we know, or we learn that certain SNPs are associated with very debilitating chronic diseases, then could create anxiety, right? Anyways, so the clients also should know, or should ask, so how is my personal information stored, both at the company level, or at the, in the healthcare system, or at the healthcare professional's office? Like, how will you store and make sure that my results will remain confidential? So that's another thing we have to think about. Privacy is another important issue, because we could see genetic profiling happening, actually. So you can imagine that insurance companies will be very interested in knowing your genotype, or if you're at risk of a disease, or breast cancer, let's say, or any chronic disease, or your employer. The other examples are a bit, extreme. School athletic team and financial loan. I mean, it could hypothetically happen, but really the employers and insurance, you really want to make sure that you're not going to be discriminated during an interview, or if you want to be insured for, life insurance. Fortunately, in Canada, there's something that protects us. I'll talk about it in the legal section, but it's not like that necessarily in all countries. I'll come back to that. But since Mr. Aurora is a taxi driver, so he has a precarious job, he might have a crappy insurance, right? And who knows, maybe not in Canada, but if he lives in Pakistan, he could maybe lose his job or not be insured anymore and so he needs to know that before undergoing this genetic test, right? We have to inform them. This is interesting. It was published in Nature. So this Dr. Ehrlich, I'll read it. So his lab showed that it's possible to discover the identities of people who participate in genetic research studies by cross-referencing their data with publicly available information. And he adds, all it needs is an internet connection. So basically he took a database that's really private, protected, research database, and he how do you say that, cross-reference it with publicly available data, and he was able to, I believe, identify 5% of that database. So we tell people, no, it's going to be private, you'll never be identified, but you have an internet connection, you're a hacker, or you have a kind of good knowledge about how to do that, it's possible, right? So it's a little scary, but I don't want to scare you, but we have to think about it, and we have to think about how can we better protect that information. This is a study that's interesting. They did 8 focus groups, and they talked about nutrigenetics, actually, and how it can be used to prevent obesity or manage obesity. And so they talked to 27 healthy individuals and 21 overweight or obese individuals, and they asked them, so what do you think about that, this nutrigenetics or nutrigenomics field? And here's what they said. It's interesting. So they asked about, should it be covered by the public sector or should it be private? And they said, well, of course, the most equitable option would be the public health system, but it would be less accommodating. Think about it. We have such a long waiting list to have a surgery or to see a specialist. What about having a genetic test that's not, might help you to prevent a disease, but, it will put more pressure on the system by adding more costs and more tests. Obviously, they said that the private service was more accommodating, but again, the highest limitation was cost. Again, those who can afford it, will pay for it, but others might not, or might have other priorities. So it comes back to this inequality gap. Then they asked about, should it be based on income or medical history, the priority of using that service. So they said, well, again, income should not be a barrier. The poorer should not have access to it because they can't afford it. So they thought that the government should provide some kind of assistance, but then it should be based on family history. So again, they said, well, a physician should evaluate your risk and then decide for you, I guess, if you're a priority or not. Okay? And then they mentioned, well, it should be based on the priority should be based on adherence to the diet. So, okay, yeah, we're ready to pay the test for you, but if you don't adhere, if you don't follow our advice, then we don't follow you anymore. And you know how obesity, how losing weight is difficult, and maintaining that weight is even more difficult. So they were saying, well, if you can't do it, just bye-bye, right? So these were some ethical considerations. Now we'll move to the social considerations. So will he be able to or have to change his entire dietary pattern, or we'll just tell him, well, eat more broccoli? What if he doesn't like broccoli? What if he doesn't eat broccoli? Will he be motivated enough to make those changes? And what about sharing this information with his children and grandchildren or wife? How will he deal with that? So you have to remember that the determinants of eating behaviors are, multiple and very complex. And eating is part of our identity. It's part of our culture. So this is an Indian meal. I don't eat like that, but I'd be happy to go out for lunch with Peter at an Indian restaurant. It looks delicious, but it's not part of my identity. This is not what I eat, but this might be Mr. Aurora's meal, and he probably eat with his family. It is also associated with emotions. You know, there are some things we eat when we're happy or when we're sad, perhaps. It will be determined by cost. You know, we might want to eat caviar and lobster every day, but it's too expensive, right? So also, this is another determinant. Availability. If it's not on the market, you can't buy it. And education and pleasure. So I'm from Quebec, and do you know, who knows the poutine, French fries and gravy and cheese? You know, not very healthy, but a lot of people love it. So you might love it and you might eat it because you love it, but because you're educated and you know that it's not really healthy, you might just cut down on the number of poutine you eat per every year, I guess. You know, so it's very complex, and biology and genetics is one other factor, but we shouldn't just think that by telling you, oh, you have this gene, just change that in your diet and you'll do well, right? It's really complex. And just to do a little side story about this, you have genetic determinants of taste, and I personally, I'm a super taster. Was tested in the laboratory. I'm homozygous for a variant on the taste, on one of my taste buds for bitterness taste. And so I'm very embarrassed to say that I don't like red wine, I don't like beer, I don't like coffee, I don't like Brussels sprouts because it's too bitter. In my mouth, it really doesn't taste the same as you, or most of you in your mouth, right? So even though you tell me you really need to eat broccoli because it's good for you, or you need to drink 1 glass of red wine per day, it tastes like vinegar for me. I could not follow that advice because I'm genetically determined to not like it, right? I tried to drink red wine just to be socially accepted, but it doesn't work out. So anyways, just keep in mind that this is very complex, and just taking genetics as one thing out of all these determinants may not work. We have to take that as a whole. This is a little extreme. So Erasmus was a Renaissance philosopher, and he said something like, a meal without conversation and pleasure does not contribute to a life that is worth living. I mean, it's a little extreme, but again, it speaks to the fact that eating is very social and it's associated with pleasure. So we have to be careful with what kind of advice we tell people if we want them to be motivated enough to change their behavior. So speaking of motivation, having the knowledge doesn't mean that you will change your behavior, right? We all know that we should eat, let's say, at least 5 portions of fruit and vegetables per day, yet a lot of people still don't do it. Coffee intake, some people would like to like I have a colleague, he loves coffee, and he knows that he should decrease his consumption. He tried it for 2 weeks, but he gave up, right? He loves it, he needs his coffee. But he's actually a professor in human kinetics. He knows that, it's not good to eat too much coffee. Again, well, that might be different based on your genotype. Anyways, I'm not getting into that. But anyways, even if you know something, it doesn't mean that it will translate into changing your behavior. However, some people might be more motivated than others to change their behavior. If you're at higher risk of a disease, let's say that breast cancer runs in your family, you might be more motivated to change your lifestyle, or some people are just motivated, just highly motivated, and they might change. But if we talk about the general public, might vary, right? So some people might say, well, I have the good version of the gene, so I'll change, I'll eat healthy because I'll live longer. And other people might say, I have the bad version of the gene, there's nothing I can do. Or other people can say, I have the bad version of the gene, I should do more, right? So it all depends, and we have to assess a person's vision on that. Like, so what do you think? If you have, even before doing the test, we should tell them, so what if you have the bad version, or what if you have the good version of the gene? How will you react? Will it really help you or motivate you to change your behavior? And if the answer is no, like my colleague, even if he knows that he's at risk of myocardial infarction if he drinks 4 or more cups of coffee, if he knows that he can't decrease his consumption, what's the point of doing the test, right? Okay, so I'm talking about food for me again. So this was an internet-based randomized controlled trial with 4 groups. So the first control group, and then there were 3 personalized nutrition groups. So the first one was just, advice given based on what they ate, what they ate, and, you should change this and that. And then the other group, they added phenotypic information, so probably height and weight and perhaps blood pressure. Oh, well, you have high blood pressure, you should decrease your salt consumption, sodium. And the third group also included genotypic information. So, well, you have this and that variant, maybe, you should make that change. And they recently published in this year actually, and there was no evidence that including phenotypic and phenotypic plus genotypic information enhance the effectiveness of personalized advice. This may be because it's complex, changing your behavior is complex. Maybe because it's internet-based and there was not a healthcare professional there to, encourage you or personalize even more or discuss with you what about cost, what about culture, what about other aspects, right? Okay, population versus individual. When we think about nutrigenetics, we think about individualized, personalized one-on-one advice, but it could actually be used at a population level. So let's say that in one population, one genetic variant the frequency is very high, and in that condition, you should consume more plant sterol. Well, maybe we'll choose to, in that population, fortify, a lot of food with plant sterol because most of the people in that population carry that beneficial or responsive genotype, but in another maybe Asian population, or I should say maybe African population, maybe it's the other way around, so we should not fortify food in that population. But again, any population won't have like 100% carrying that allele. You'll always have a subgroup carrying the bad, like the other version of the gene, so what do we do with them? Again, we have to think about cost effectiveness. Do we really want to genotype or sequence all the population to then gear our nutritional policies? We have to think about it, but really we need high standards, high evidence, a lot of science and replicated studies to make before we move on with nutrigenetics in the public sector. This is a nice example, though, of the application of nutrigenetics into the public health. So this is the Ontario Ministry of Health and Long-Term Care. So newborn screening. So you gave birth, so your baby probably, well, not, I guess so, was screened for rare genetic diseases. So it's rare, so only 200 children or newborns will be affected by a rare genetic disease out of 145,000 births. However, when it's your own baby that's affected, you want to know, right? And this is a good example because the gene and the variant is very clearly determined, and the nutritional component is very well known as well. So phenylketonuria. So you have a variation in the gene that converts phenylalanine into tyrosine, 2 amino acids. And if you have a defect in this gene, it won't be converted. So if you carry this gene, the only thing you have to do is to remove or ban phenylalanine and alanine, whatever, from your diet, right? If you don't do that, you'll have neurological problems. It can be very devastating. But if you do remove that from your diet, you're fine. So you want to know, right? So this is an application of nutrigenetics in the public health sector. Now, this is a rare and simple interaction, rare disease with a simple interaction with one nutrient, an amino acid. However, most of what we're trying to prevent are common, complex, polygenic diseases, right? So we have to think about how nutrigenetics can be applied at the population level in terms of those complex diseases with a lot of nutrients involved, a lot of genes involved, gene-gene interactions, gene physical activity interactions, etc. It's complex. Now, we can think about the use of technology. How can technology assist or help people adhere more to those personalized, or help or have access for cheaper to those services? We have to make sure that first of all, it's effective. And sometimes, having an app on your phone or whatever, it's easy. and it might be cheap, but is it the most effective and the healthiest choice? You know, sometimes having a healthcare professional who knows and who can actually give you even more personalized advice and take into account so many other factors that the computer won't really ask you about. You know, but anyways, there are, you know, Peter showed some companies that are this online Pong app, so personalized online nutrition guidance. So it gives you a daily personalized menu, and it takes also your genotype information. There's this technology-assisted assessment. But that doesn't take into account the genotype. There's nutrigenomics. There are a lot of companies out there. Some might not be just like an app. Some might be just like, a company that will offer you the service, and they will actually send you a report. But these are more like applications that you can fill out daily, on a daily basis, and it'll give you feedback, more periodically. I mean, will it really be useful? We need to test it. Oh, family. Okay. So once you have your genetic information and your partner's genetic information, then you can start thinking, well, you know, we both have those variants. What about our kids? If we're homozygous, it means that automatically our kids will carry both of our variants. Right? So this is a little extreme, parental embryo selection, but still, if you know that information, how will you pass it on to your children? Or if you're both tested as a parent, there's a possibility that your kids will automatically know their genotype without being tested. So do you want to talk to them before you're being tested? Or maybe you want at least to be informed before you get tested, right? Because again, there might not be any problem now, but you might learn in 10 years that you carry a variant that's associated with high risk of a disease, and that can cause anxiety, right? So it's important that you know that before you make your decision. Okay, now how can we actually translate research results into clinical application, and how is it generalizable? So you have to know that most studies were done in Caucasians. They were done in adults, very few in adolescents, and none in seniors, at least maybe more recent studies, but as part of this study, out of 173 studies that were evaluated, none were done in seniors. So again, if your client is a senior, or if it's an adolescent, you know, your nutritional needs changes, and even gene expression changes with age. So we have to take that into account. And most of the studies were done in Western countries. So North America, Europe, a little bit in Asia, but nowhere else. Okay, so the issue is that, let's say that in Caucasians, this is a marker that your genetic test, the company is actually looking at G at this position on this gene. But it happens to be a marker. It's inherited all the time. In Caucasians, it's inherited with the T variant at the other position. And it happens that this T allele is actually, or SNP, or variant, is the functional SNP. And this will actually change the protein structure, or change the amount of protein that is being produced. Fine, because this is, every time, you know, if you carry this, you'll also carry a T if you're a Caucasian. But let's say you're an Asian or an Indian or whatever, maybe that this G that this company is measuring in another population is inherited, is in linkage with an A. And the A doesn't have the same consequence on the protein function. So you might give an advice that will actually not work at all in other populations, and you have to remember that most studies that we're basing our advice on were made in Caucasians, adults, you know, Western countries. And in big cities in Canada, we have a very diverse audience. You know, it's very multi-ethnic. So what do you do as a healthcare professional if it's Mr. Aurora that comes into your office? Will you feel confident to give that person the advice? I mean, if we don't measure a marker, if we actually know that we're measuring the functional variant, I would feel more comfortable, but if we are not sure, not sure. Okay, so these were social considerations, and now we'll move to legal considerations. So again, I talked a little bit about it, but could he be discriminated from his insurance or employer, or will he have legal recourses if anything happens, or if need be? So obviously we do need to regulate this field. We do need to regulate genetic testing because of all the possible consequences. We want to make sure that the tests are being accurate, that we don't give false results. It needs to be clinically valid, so the interpretation that we're making of the studies and the actual results or report that comes from the company, has to be well interpreted and well discussed or to the client or disclosed anyways. And the clinical utility, will it actually help you to reach your goal? Will it actually really decrease your risk of developing a chronic disease, whatever, myocardial infarction, type 2 diabetes, knowing that it's very complex, right? Eating behaviors are complex, and the determinants of health in general are very complex as well. So, okay, so in Canada, the direct-to-consumer genetic testing is regulated by both the federal and provincial, at the provincial and federal level, so by the Personal Information Protection Act. So I'm not going to go into any details here, but you have to know that it is regulated in Canada at both levels. In the States, just because some people might come from the state here, or just as a comparison, it's regulated by 3 agencies. So the first one is the FDA, and they regulate the tests that are made from a laboratory that distributes to several, that are sold to multiple laboratories. And this Centers for Medicare and Medicaid regulates the tests sold by a company that sells directly to the client. And then the Federal Trade Commission regulates all clinical labs, but they just ensure that, they make sure that what's being advertised is actually accurate and that there's no misleading information. But they do not at all make sure that the lab technicians are competent, or that the tests or the methods are being, are the right methods are well performed. That's not being regulated or evaluated at all. Now this, just has made the news. Genetic non-discrimination bill opposed by insurance industry, set for debate, of course. How genetic testing can be used against you. So, and how Bill S-201 could change that. And again, home DNA tests may affect insurance employment. So it really is a concern in the population. And fortunately, this bill has passed very recently, this year actually. So what this bill does, it prohibits any person from requiring an individual to undergo a genetic test or disclose the results of a genetic test as a condition of providing goods or services. But before that, we were not protected. And there's a similar act in the States, but in other countries, not necessarily. So again, Mr. Arora in India or in Pakistan could technically lose his job. Have you done a genetic testing? Yeah, you have to tell me. If you want the job, you have to tell me, disclose the results. Or if you want to be insured, I need to see that report that you got from that company. And we'll see if you're hired or if you can be insured. So again, you need to know that before you make the decision to take the test or not, right? Because if you could lose your job, it might not be worth it. Okay, so the conclusions, this is a conclusion from a report from the Omics Ethics Group from the Université de Montréal. They did a survey among researchers, and they say that, and they also, when I showed the study looking at, the 173 studies that were done in Caucasians, adults, and in Western countries. This is part of this group and this report. So what they conclude is, despite this optimism among nutrigenomics researchers, we suggest that the potential benefits of nutrigenomics, along with other genetics and genomic clinical applications, require balancing with potential social ethical risks. And they say in particular, tension between social cultural meanings surrounding the medicalization of food and the impact of nutrigenomics on individual autonomy and responsibility warrant further attention. And I guess this is my own conclusion. I mean, yes, genetic information can be useful. If you're an adverse responder, right? You want to know before you buy omega-3 supplements or plant steroid supplement. You want to know if it'll do good or bad, right? So once we have enough studies that are replicated and we're confident in the science, I think that it will be another tool that we can use. But we have to keep in mind that this is one tool as part of a big picture, and we'll need to use many other information, including, and we'll need to know how to actually analyze this complex information. We'll have to keep in mind this social cultural aspect of food, of eating behavior. Microbiome is a hot topic right now, and it's related to different health outcomes. So again, yes, it's important, yes, it could be useful, but keep in mind the big picture. So any questions?